But, hi. Okay. Last lecture. Isn't that crazy? And then you guys are going to be fourth semesters. Okay, this is HIV. Clearly ending on a happy note, right? So I was traveling in Laos, and I can admit to not knowing much about the world, but I was approached by some boys in Luang Prabang who wanted to practice their English. And so I was chit-chatting with them, and the next day they said they're going to have an English class, and they're always inviting tourists to come so that folks from the town can come and learn English and just speak, talk about whatever. And as a teacher, I was like, that sounds great. I'll go. This is about 6 years ago, 7 years ago. And so I show up the next day where they told me to go, and there was a lot of monks in this town. It was a daily procession that the monks would walk through, and the people of the town come and bring them food. They don't make their own food. They don't ask for food. It is provided to them by the people of the town. So I went, and there was a monk in the group that I was going to talk to, and he was young. He was probably like 15 years old, I'm guessing. And so I thought we were going to talk about, American culture or something like that. I didn't know what they were going to ask me about. Wrestling. I don't know. And the monk kid said, "Can you teach me about AIDS?" I was like, what? And it was like a group of, teens and adults that live in the town, probably like 5 or 6 of them. And so there I was explaining HIV and AIDS to what I'm guessing was a 15 or 16-year-old monk. And I didn't know you're not supposed to touch them. And so yeah, I know I'm very hands-on, unfortunately, especially for him. And when I said, like, you cannot transmit it by hugging, and I touched his arm, and he went away like this. And I said, oh, I guess I'm not supposed to touch a monk. And that kind of makes sense if I really think about it. So just an odd, funny Francis story to get us all started here today. So we're going to talk about HIV and AIDS. And to give you some perspective, and this has a lot to do with implicit biases, inequality, even at, healthcare level. When COVID was identified in 2019, they had a vaccine within months in 2020. Okay, so I got the order to stay home beginning of March of 2019, and by January I was getting my first vaccine. Actually, I think by December I was getting my first vaccine. So that tells you something. That tells you if you come together and you see a problem, you can handle it. In the 1980s, when HIV and AIDS was being recognized as a disease, that started in June of 1981, and it wasn't until 1985 the first test was developed. Whether that is because the technology wasn't there, or if it was maybe because they were only seeing gay men dying from this and some straight people who got caught in the crossfire, the viral crossfire. I don't know, but it's just worth mentioning. There are still countries on this earth that deny that HIV/AIDS is a problem, and that is more so because if you admit to it being a problem, you have to be responsible for that. And that means economically, like taking over the care of your people. And I was in South Africa in 2007, and they still had deniers everywhere that this was not a real problem because the president at that time was an economist, and he knew that if he admitted that this was a problem, he was going to be responsible to pay for it. So, just keep those in the back of your mind. So statistically speaking, I've updated this. In 2020, there are 280,000 deaths. In 2024, 630,000 deaths. I don't know if this is somehow related to the pullback of U.S. Help. When the Trump administration took office, they, started retracting all of the not-for-profit work that was being done with those funds. But it might have something to do with it, and maybe not. Maybe it's just that with the onset of COVID and people coming out of the pandemic, maybe there's just more going on. But that's a huge jump. And then in the United States, 1.2 million people are living with HIV, and 13% are unaware that they have HIV. So that's worth noting. And it's the reason why we talk about safety around this. Hospitals started their gloving and gowning and washing because of HIV, because they wanted to stop the spread. And now it's called standard precautions because of HIV. And we notice that it actually works. So yeah, 63% are gay or bisexual men, 25% are women, IV drug users, or children. And there's only been one case of understood and known blood transfusion HIV since 2004. So that's good to know. Gerontological considerations, the HIV community is getting older. They are living older with the disease that used to kill them off very quickly. But when we figured out what was going on, now we actually have people in their 70s and 80s who have HIV, who've probably lived a pretty long life, either with it or contracted it more recently. And again, they're still having unprotected sex. They don't consider themselves at risk because they haven't been around it, I guess, in a couple of decades. The 80s is a faint memory to them. There's definitely a social bias toward the homosexuals, and that nobody seems to understand that there's actually a crossover, that sometimes homosexuals are actually married and have children with the opposite sex, but still engage in a lifestyle outside of their marriages. So there's still shame around this that we have to sort of break people out of. IV drug use is still an issue, and those before 1985 that received blood would have received it potentially contaminated with HIV because they weren't doing the precautions of the blood cleaning before that. And then, of course, there's always the older folks have a reduction in the immune system function, which we've talked about. Okay, so we have stage 1, stage 2, and stage 3. So stage 1 is where remember the CD4 count? That's your T helper cells. So I'm going to call it T helpers because I'm trying to remind you guys that CD4 means T helper. So if your T helpers are above 500, you seem to be like you're okay. You're probably dealing with some reduction in your immune system functioning, but you're stable above 500 T helper cells in your system. When you start dropping down to 499 to 200, you're in stage 2, and you're still probably okay. You can probably live your life, but you do need to be mindful that your T helper cell levels are dropping. And by the time they drop below 200, you now have AIDS, full-blown AIDS. And so this is something you guys need to know. Let's see. So the immune system produces and protects the body from the infectious agent, old, destroyed cells, foreign objects, splinters, all the way to transplanted organs. Sometimes they actually reject transplanted organs. But in an HIV-infected individual, their immune system is not working at a high level because of the destruction of those T helper cells, because the HIV virus actually targets those T helper cells. And the way you get HIV, of course, is through blood, semen, vaginal secretions, and breast milk. And you have to know this, so make sure you guys pay attention to the slide. Sex with an infected partner. Hopefully it's protected, but sometimes people are not using protection, and birth control pills, things like that, are not protection against this. It needs to be a barrier type of protection, like a condom, spermicide, all those. IV drug abuse or sharing needles, also you can contract. And pregnancy, mothers can give it to their babes, but my sister has told me, she's a perinatologist, so she deals with high-risk births. They're doing a much better job at starting mothers on ARTs through the pregnancy A vaginal birth can be had if they're on the treatment, and then the baby gets treated once they're born, and hopefully we can prevent the transmission of it through these types of programs. And then, of course, that's delivery and breastfeeding can also transmit it. So you just have to find ways to help families have babies with the disease. All right, so viral transmission, acute viral infection, and seroconversion. So there's a lot going on with this slide. The main thing that you want to take away from this slide is viral load at the very bottom. That is the amount of HIV virus that is in your blood. And that is what we're targeting when we're looking at testing, when we're looking at treatment, and looking at prognosis. We're looking at viral load. So that's your takeaway from this slide. I have a little picture here. Excuse me, I'm going to turn on the light real quick so that you guys can see me better. All right, so this picture tells you how this virus does its thing. Like, you know, viruses only have RNAs. They need DNA in order to transcribe and make more of themselves. My goodness, my brain today. So they have to find a cell that can help them do that. And then they get their RNA into the DNA, and then they can start using the cell's processes to create more of themselves. And then that's how you develop your viral load, is through this process. So initially, a patient could experience flu-like symptoms. And this is probably after a few months of exposure. They might have a little low-grade fever, aches and pains, maybe some swollen lymph nodes, and just not feeling great. And then after several weeks, they can seroconvert or go through seroconversion, where the antibodies that your body has made against the HIV rise to detectable levels. So now we can test somebody. So clearly somebody who's had sex with somebody who is HIV positive is not going to know for quite some time, but they should continue getting tested, and we'll go through that schedule. All right, so asymptomatic chronic infection. This is where you have your viral set point. So the amount of virus being created is kind of equaling the amount of virus that the body is disposing of. So you're kind of creating a set point where you're not moving from that place. But eventually, the immune system is unable to keep up. And now that's when you're starting to monitor and see more symptoms of the disease in your patients. Symptomatic chronic infection is where you start to see the T helper levels decline, reducing the body's ability to actually fight off infections. And it's not just the HIV infection, it's all the other infections like respiratory infections, skin issues, lymphadenopathy, and they start going through a lot of weight loss because they just are probably nauseous, their body is just metabolizing too fast, they probably can't keep up. And one person can become symptomatic. The development of AIDS is usually within 2 years without treatment. And it was horrifying to watch this in the 80s. I was still pretty young, but I remember buildings being inhabited by people who were dying of AIDS, and nobody would see them, hospitals wouldn't take them, so they just were homeless and usually holed up in empty buildings together, dying. It was horrifying. And it was horrifying the fact that our society treated them so poorly. So AIDS, your T helper count continues to fall to the point where now random infections called opportunistic infections, or OI, can start occurring. And this is a small list of those OIs. You have the pneumonias, the pneumocystis, Javorvashi pneumonia, we call it PJP, I can't pronounce it. The Mycobacterium avian complex, toxoplasmosis, esophageal candidiasis, and recurrent bacterial pneumonias. Pneumonias are probably going to be the number one thing that's going to take out somebody with AIDS. But toxoplasmosis, that's what you get from cleaning your cat litter. So that's avoidable, but it's also just something that exists with cats. The esophageal candidiasis is that infection that can go all the way down. It's a yeast infection. the Mycobacterium avian. These are usually things that your body is pretty good at defending against, but once your T helper cells start to go down to less than 200, remember, then you're really vulnerable to these other diseases. And then, of course, the target organs for damage are always kidneys, your nervous system, both peripheral and central, and then, of course, the cardiac system, because whenever your kidneys go down, your heart goes with it. They kind of go hand in hand that way. So, yes, this is this is a clinical manifestation list. It's pretty all-encompassing. Of course, anytime you hear someone losing weight, you wonder what's going on. That's usually a number one indicator for things like cancer, tuberculosis, but also for HIV and potentially AIDS. A lot of these things can just be like, I ate something bad, I got a bad cold, I'm not able to shake off, I've got the flu. And so it just keeps going and going and going, and they don't seem to be able to fight these things off. So you can see from this list that it's probably hard to admit that there's something larger going on when it just seems like low-level viruses. And then you start seeing the signs and symptoms that require you to go and see a doctor, right? So the new cough, the fatigue that's keeping you in bed or keeping you home, these fevers that keep coming and going, and then, of course, night sweats. And if you guys remember, night sweats can also be associated with tuberculosis. So we're always worried about night sweats. New onset of headaches. That's never a good thing, especially if you've never really dealt with headaches. We don't like hearing that. And then the visual problems that come with it. We'll talk a little bit more about what usually causes that. And then skin lesions that you're like, what is this? I remember in the 80s, just people having these big purple lesions. And that's how you knew they had full-blown AIDS. It's called Kaposi's lesions. It was pretty sad. Just lots of diarrhea, so then they can't maintain water levels, they can't keep nutrition in, so then their weight loss starts to really take effect. And then there's actually kind of a predictable way that the clinical manifestations can be emblematic of something specific. So like when you start to see the weight loss, you know that your disease is worsening, right? Because you can't keep your weight on. You have fevers. Now I'm pretty much have an infection. I just know that's what my body's trying to fight an infection. Night sweats could potentially be that mycobacterial infection. A cough could be pneumonia, tuberculosis, and so on and so forth. So we know from dealing with these patients now for decades that we can kind of track what's going on with their opportunistic infections based on the symptoms that they're showing. And then a timeline for untreated HIV infections. You can see the early chronic infection. You have the acute viral syndrome in the beginning where you have like flu-like symptoms. And then maybe your HIV antibody test becomes positive between 3 weeks to 3 months, because remember, it takes a little while to seroconvert, where you're going to have enough antibodies for the test to pick up. And then you have the chronic infection. And without treatment, you just start losing your T helper cell levels, and you start becoming more susceptible to other problems until you end up in AIDS and probably are going to pass away from like a pneumonia. So the testing, which took years and years for them to develop, and it took us, 8 months to develop a COVID test. So tech, bias, who knows? So the rapid tests are the ones you can do in the clinic. Usually it's a spit, sometimes blood, and you just have to wait a little bit and you can get your results right there. So that's pretty important because we don't have to send these things off and wait. We don't have to send this person back out into the population. We can keep them right there until they know what's going on and then have conversations with them about what they need to go and do next. And if the results are positive, you have to confirm those tests with one of the longer acting tests. Let's go through those. So the EIA is also called the ELISA. And it's pretty much the gold standard, I think, for the second testing when the rapid has come back as positive. Western blot's also fine. You're really looking at the CD4, the T cell markers, to see what's going on with those. How's your immune system functioning? And the Aura Quick is the one that they can do at home, especially when they're on treatments, to just monitor if their treatments are working. All right, so frequency of testing. We're looking at every 6 to 12 months, 3 to 6 months, 3 to 6 months once your test is negative, but you've been exposed or you are engaging in high-risk behaviors. And so then every 3 to 6 months you'll test just to see if you have gotten it. And now there are medications that you can take if you are engaging in high-risk behaviors, where you can try and keep HIV from taking on a viral load in your body. And I'm going to add that at the end because it's not a BRN thing. It's a you should know about this thing because your patients might be on it, and compliance with those meds is very important. And so they may need it while they're in the hospital, and you may need to advocate for them to continue taking it. And so all those slides will be at the end. So this is a negative screening test every 3 to 6 months. But now we're also checking our babes when they're born from HIV-infected moms. And because they can still carry the maternal antibodies up to 18 months after birth, we're continuing testing with our newborns until that 18th month point. We're doing what we can during pregnancy and birth to prevent transmission, and we're doing pretty good. But we also want to check them after birth. Okay, continuing frequency of testing, routinely every 3 to 6 for the first 2 years of therapy, and then every year. So this is a positive test that now you're treating with medications. And the viral load obtained every 3 months for the first 2 years of therapy, and then 6 to 12 months, especially if you're responding well and your T helper cells are staying at a pretty consistent level. So again, viral load test. Oh, by the way, this is slow number 7. Let's see. So far, we have covered slow 1, 12, 4, 2. Yeah, I'm jumping all around, aren't I? 8, 5, and now 7. So it measures the amount of virus in the serum, and the cerumen, sorry, that means the blood. Serum. It reflects active viral replication, so it's what's actively happening in the body. And it looks at the plasma HIV RNA level. So this is real specific. This is not necessarily an antibody test. This is a viral load test. And it helps to monitor progress to see if they are transitioning from that stage 1 or 2 into 3 for AIDS. And it monitors the effectiveness of an antiretroviral drug therapy, or ART. And it's not used as an indicator for hospitalization, because if the person is able to manage their symptoms at home, they can stay at home. And it's only when they're no longer able to that would say, okay, now it's time for you to be hospitalized. So screening, we're looking at newly diagnosed HIV positive patients should be screened for other things, because we know that if their body's immune system is going to be put into a vulnerable state, we want to see if there's anything we can vaccinate them against and or expect treatment for. And that includes hepatitis B and or C. And then, of course, those with the AIDS, the ones when their T helper cells have gone below 200, we're looking for those other things like the toxoplasmosis, TB, syphilis, and then we're monitoring their end organ function. So we're making sure their red blood cell levels are up, hemoglobin's up, their kidney diseases are managed, liver diseases are managed, diabetes is managed, and that their cholesterol levels are where they need to be. And then they can also actually get gene sequencing from the virus now, so they can figure out which people are going to have resistant virus to certain antiviral therapies or antiretroviral therapies. So, the genes of your virus say this, so we're not going to give you this treatment, we're going to give you this one because we know it's more successful. And I think we talked about this with cancer too, where they can look at the genetics of the cancer cells and figure out what's going to be the most appropriate treatment for that person. And that's really important to know. Okay, medications. So those HIV positive folks with that T helper cell count of less than 200, we're doing a lot of prophylactic medication. We are making sure that they are on on meds that can help reduce the virus, but we're also treating the other things that they could potentially contract during that time. And so once we have gotten down to the 200, we can go off, or sorry, when we've raised up to 200 or greater, we can go off the prophylaxis. It's the prophylaxis for like things like toxoplasmosis and then that pneumonia, the PCP, will be if their T helper cells have gone below 200. All right, so ART, or antiretroviral therapy. This is what is recommended for all HIV positive individuals. There's a bunch of different combos of drugs that we can use. Table 22.3 can help guide you on that. And you're going to be responsible for understanding the side effects and what we're monitoring for these patients. So let's see. Generally, it takes 6 weeks to achieve an HIV viral load to a non-detectable level. Do you think you should go off your meds if now your viral load is not detectable and you're HIV positive? Correct. You do not go off your meds. So just because it's not detectable anymore doesn't mean that you stop. It means that your treatment is working, your ART or your ART treatment is working. So adherence, and this is slow number 6, is very important. So compliance with medications, and that's kind of where you come in as the nurse in helping your patients who say they're on these different medications to continue to get them and to make sure that you're working with the docs to also treat whatever they're dealing with in a way that it doesn't compromise their absorption of their current medication systems. So this is a really important slide because you need to understand therapy adherence, the advantages and disadvantages of therapy. You're going to be having a lot of these conversations, especially if you're an outpatient nurse working in like a free clinic, something like that. So you're going to need to have these kinds of conversations with patients, or if they happen to be your patient in hospital or even out of hospital, being able to help set up the path for them so they can understand what's up ahead of them. So you want to make sure you are saying therapy adherence is very important. You want to talk about the side effects and how you don't go off your meds. If you do have side effects, you let your team know so they can help you with those. Because remember, that's a lot of what happens when people are non-compliant with their meds. It's usually because of side effects. But that could just mean that the dosage is too high and you can maybe come down, or one's too high and one's too low. There's any number of reasons why a side effect symptomology could be problematic. But you can also solve it if you talk to your team instead of just going off the meds. So this is also something that we talk about a lot with people who are active drug users, maybe homeless. Sometimes they don't have watches or phones to monitor when they need to take their meds. And so you might want to start working with them on using the sun, having an idea of writing down when you've taken it so that you can keep track of when you last took it, which has got to be hard for people that come sort of in and out of reality, but it'll be very important that we don't continue spreading this disease or that they don't get sicker with it. Okay, so here's that table 22.3. And just so you guys know, this is actually quite important. Oh, I think my screen is going off. Hold on, let me open this up a little bit. All right, here we go. There you guys are. Okay, so you can see that there's a list of something called NRTIs and NNRTIs, and then a bunch of other types of meds here. The next few slides are going to actually go over all of these, so we're going to discuss those in just a moment, okay? I think we lost my picture, but I'm okay with that. Hopefully you guys are too. Okay, so NRTIs. If you see an NRTI, you can pretty much guess that it's going to inhibit something. If you're going to see a double N, you know that it's probably going to alter something. That's just a little cheat sheet. So NRTIs in general, let's go back actually. NRTIs are going to have very specific mechanisms of action and very specific adverse effects. Lactic acidosis is one of those things. So you're going to want to make sure you're comparing and contrasting NRTIs and the lactic acidosis. They are also known for their peripheral neuropathies, which is not in the book or in the slides, but I want to make sure you guys know that. And then also anemia, diarrhea are all issues with an NRTI. With the NNRTIs, you are looking at more like lipodystrophy. It's where you're putting fat distribution in odd places, and it doesn't look right. Your body starts holding fat in stranger places. And so that's something to know with the NNRTs. So here's the first one, virate. The thing to know about these ones, of course, are taken with other ARTs, because usually these are cocktails of medications that you're going to be taking. The one here, look at those monitoring. You're going to keep watching those kidneys, those livers. You're going to be watching those blood levels, the bone density, because remember the bone density issues with NRTIs, and then of course the chem panels for the phosphorus, and then doing UAs for them. All right, Zymogen is another one that's an NRTI. Hold on, let me catch up with my notes. So again, inhibiting enzymatic processes of the reverse transcriptase, so that when the RNA gets stuck into our cell's DNA and then gets recombined and created, what we're trying to do is inhibit that process. So again, with Zymogen, you're going to be looking at your CBCs and your liver function test, and you can take these with other ARTs. Okay, continuing with slow 6, you have Intelins, and again, you're inhibiting, this is an NNRTI, so this is going to be altering enzymatic reverse transcriptase. And you're going to look at what you're monitoring here is, again, your liver function test, but you're also going to be monitoring your triglycerides and your cholesterol, especially the bad cholesterol, the LDL. With a protease inhibitor, what you're looking to do is monitor your liver function tests and look at this adverse reaction, that lipodystrophy, that fat redistribution, the buffalo hump on the back of the neck with large breasts can also happen with the PIs. Fusion inhibitors, you're looking at monitoring for pneumonia and you're watching their body weight. And look at these side effects with the nasal congestion, nausea, fatigue, malaise, and then you have muscle joint pain. So you're definitely monitoring, because you could think something is a cold, but it could actually be a side effect of the fusion inhibitor. The CCR5 antagonist, this is a protein on the, what have I written down? This is a protein on the, what did I put there? Of immune cells. On the surface of immune cells, or in other words, a co-receptor. So you're trying to shut down that co-receptor. You're trying to antagonize it, and you're monitoring those LFTs, and you're watching for signs of infection. An integrase inhibitor, this is a viral enzyme that catalyzes the viral DNA insertion to the host. So you're going to try and shut down the ability of the virus to insert itself into the DNA of the host cell. And again, monitoring CBC, monitoring renal function and liver function tests. And then of course, post-attachment. Here we go. Post-attachment. Yeah. Post-attachment inhibitor. So of course, after it's already attached, we're trying to shut it off so it doesn't keep making more of it. Monitoring very similar things, CBC, renal function tests, and liver function tests. And now we're talking about the new combinations of the antiretroviral therapies. So you can take multiples together, you get a bigger bang for your buck, and having that, that gene understanding of the virus will help guide which one you are going to be using. Immunizations are really important. You want to make sure that you're communicating with your patients, that they stay up on their communications. You want to give their immune system a fighting chance against the lowering of their fighters. So this is really important, okay, guys? You guys should know this slide. The pneumovax every 5 years for HIV patients, and I believe that's the way it is from 65 and up, although they may have lowered the pneumovax for the general public now. But especially for patients who have a count of over 200. So we're trying, when they're under 200, we might not be pushing immunizations as much because we don't know if their body can handle it. But prior to that level, we're going to be pushing these things because we want them to be able to fight these things And hopefully those B memory cells can hold on to that information and keep fighting things that show up. The Prevnar also for pneumonia, influenza every year. And then there's your DTaP or Tdap. It's different if you're a child or an adult. And then your herpes zoster. These ones tend to be live vaccines. So we have to monitor where their viral load is, or where their T helper cells are before we give them a live attenuated vaccine. Because it could be detrimental. But we want to make sure the rest of the people in the house are vaccinated because we want them to not bring it home to the person whose immune system is vulnerable. Complications. Individuals with AIDS, so it's usually, of course, related to immune function. That's pretty much the theme of the day, isn't it? When the T helper cell count is greater than 500, we're actually in a good place, right? They don't have symptoms related to HIV, great. But just so you know, HIV positive women may have increased incidence of yeast infections, vaginal yeast infections that are unrelated to antibiotic use or diabetes, because they are sort of in hold, and maybe the bacteria are dying off because they're getting cleaner, and so the yeast are taking over. There's any number of reasons why women get yeast infections. So you just have to monitor that. And then, of course, there's always the increase in respiratory illnesses. You have to be very careful around kids when you have HIV because you don't want to get all their viruses from preschool. And then, of course, all the skin issues like the shingles and warts can be problematic because generally your body can keep those things in check. But when your fighters are lowering, they're more susceptible. And then, of course, people with AIDS who go on to develop specific OIs, they can actually reactivate old dormant infections. Like, remember, the chicken pox can lay dormant on your nerves, so that's how you get shingles later in your life. And then, of course, the IRIS, which is the immune reconstruction inflammatory syndrome, when your T helper cells go up and the immune system is able to start responding to all the OIs that are maybe sitting latently in their body. And sometimes it can be really overwhelming because you just go into this inflammatory state because it's like, okay, I can fight this. But then, as we know from COVID, sometimes the body's immune response to things can be detrimental to the body. And so this is something that happens with IRIS. And then this is a graph of where you can expect to get different illnesses based on your T helper cell count. So the shingles around 400, tuberculosis around 350. You start getting the oral yeast infections around 300. And then when you get to the AIDS or stage 3, where you're dropping to 200 or below, that's where you're getting not just the oral yeast infections, but now the esophageal, the pneumonias, because if you can think about it, you're breathing in a lot of that yeast. You're going to probably breathe in a lot of stuff, and your body can't just manage it anymore. And then below 100, you start to see that toxoplasmosis and like the valley fever cryptococcosis. MAC, I forget what that is, but CMV is cytomegalovirus. And then anything below 50, you are getting some really bad infections, cryptosporidosis, and then PML, which I'm forgetting which one that is right now, but we can figure that out together in class. All right, so nursing diagnosis for you guys to remember. Risk for infection, imbalanced nutrition, it's a bad one. Risk for fluid volume deficit, because sometimes they just have diarrhea so much. Anxiety, of course, like how do I develop relationships with anybody new, knowing that I have this thing and could, some people just don't even trust themselves to cough around anybody because they're so scared they're going to give it to somebody else. So a lot of anxiety around the diagnosis, around the social side of these issues, and then of course not knowing enough and spreading it and continuing bad behaviors. You're always going to watch these patients for making sure all their vitals are good. You're going to trend their weights. You're going to keep an eye on their virus and look at their T helper cell loads. You're going to make sure they're compliant with their meds. And to the point where I think even sometimes with new diagnoses, sometimes public health departments are calling you every day to make sure you're taking your meds. You're going to monitor your TB status, and immunization status, and then watch for that depression that can come on with having to deal with all of this stuff. And sometimes this just takes over your whole life. So this is the FYI that I've added in because I think it's important to know. I've had patients who've been on PrEP and had to advocate with their physicians to make sure that they continued with their medications while they were in the hospital. And because the hospital didn't actually carry them, their friend had to bring it in for them. So PrEP is pre-exposure prophylaxis. So this person's lifestyle is such that they are being exposed potentially. And so this medication, if they can take it and stick with it, can help prevent HIV from taking hold inside of their body. But it is a daily med, so they have to continue taking it, even if they're sick in the hospital with something else. And it's best for people that are in high risk IV drug use, working with HIV positive patients, but we also know standard precautions are good enough for that. So it's more about the intimate exposures. Compliance, again, is very necessary and needs to be done for maximum effectiveness. And these are some of the names of the meds that I found: Truvada, Descovy, and Vocabria. Vocabria sounds like a med I would take to like win the spelling bee. PEP is post-exposure prophylaxis. So if you guys are similar, if you guys know what Plan B is for women that have had a condom break or something like that and want to make sure they don't get pregnant, you have to take that med within 72 hours. That's the same for PEP. So post-exposure prophylaxis, you have to get the med in your body within 72 hours. So you do have a little bit of wiggle room, but it's not a substitute for PrEP. Like we all know, PrEP is the better one if you're going to be engaging in high-risk behaviors. So here's a table for you guys, more of a drawing slash marketing, I guess. But there's phone numbers here. This is specific to New York City, so that you can get help for keeping yourself safe. Legal issues, you're not allowed to tell anybody who's got HIV and who doesn't. You know, we're not allowed to talk about anybody's medical status, but we just want to remind everybody, you really cannot disclose these kinds of things. It's just to the person and who they choose to tell. And you have to have them sign a consent to actually test for HIV. And they can do partner notification services if the person's consenting to them, to inform your sex partners and needle sharing partners. And adolescents in California can be tested even if their parents are not okay with it, which is probably a good thing. Occupational exposure. So this is sort of related to us. This is us at work. If we have a needle stick accident, you know, we have to make sure we're telling everybody, we don't test our patients for HIV. We test them for HIV should something happen between a provider and a patient. Then both you and the patient would be tested, and then remember the schedule. So if it's going to probably be negative, at least for you, if you've always been negative, then you wait until 3 to 6 months to go back and get your next one. You'll be on that schedule. And then, of course, we find out what happened with the patient. Are they already negative? In which case, then, if it was a needle stick to you, then you're the one that continues to be monitored. If it was a needle stick to them, now they are going to be on that schedule. I hope that makes sense. Okay, and then if you do have post-exposure prophylaxis, you can use ARTs, antiretroviral therapies, and then just maintain your schedule. And then UCSF actually has a really great program for monitoring and watching and getting you the right treatment. Okay, that's pretty much it. All right, guys, have fun in fourth semester.